Pakai speaker.
Boleh, boleh.
Boleh Okay. So, Assalamualaikum and a very good morning everyone. I'm Sarah. For today's CME, I'm very honoured to introduce our speaker, Dr. Hasdi Harun. He is a clinical manager at National Transplant Resource Centre in Hospital Kuala Lumpur. So, Dr. Hasdi is going to deliver a talk about brain death, organ donation and transplantation. So, without further delay, I would like to invite Dr. Hasdi to give his talk. Hi, Dr. Hasdi.
Hi, Sarah. Hi, Dr.
Yeah.
Sarah.
Hi.
Thank you for the brief introduction. Good morning to all of the doctors and paramedics in the emergency department, UMMC. My name is Dr. Hasdi. I'm a clinical manager in National Transplant Resource Centre. I think without further ado, I just continue my presentation. Sarah?
Okay. Sure, can Dr. Hasdi.
Okay. All right. Sila.
Sekejap
Okay. Can you see the slide, Sarah? Hello? Can you see the presentation? Sorry. Hi, Sarah, can you see the slides? Hello?
I can see Dr. Hasdi.
Can, sorry. Okay, I shall start the presentation. I will given an opportunity to present to you about organ transplantation and donation, the gift of life. And I might touch a bit about brain death practice in Malaysia. As we all know, organ transplantation basically is a replacement of terminally damaged organ or tissue with another healthy organ or tissue from another person. And this donation and transplantation, the organ can come from a living patient, a living donor, or as well as the deceased or cadaveric donor. So what is organ and tissue that can be transplanted in the service, in the practice? For the solid organ, we can donate and transplant heart, lung, liver, kidneys, and pancreas. But we only practice in our country heart, lung, liver, and kidneys. Whereas the tissues, so vascularized composite allograft, which consists of corneas, cardiac valve, arteries, veins, intestinals, bones, tendons, ligaments, skin, and face, limbs or face also. So for transplant of the solid organ, we consider as a life-saving medical procedure. Whereas the tissue or VCA usually to enhance the life of the patient with some problems with the sighting and all. But for the donation of the skin, usually the skin graft also is very important for the life saving of the burn patient. This is an immediate skin grafting to actually save the patient's life. So organ transplant is not news. It has started as early as in 1905 with the cornea transplant. As the medical advanced throughout the years, which including the creation of ventilator as well as immunosuppressive drugs, so actually we are able to do transplant as well as the introduction of the concept of brain death, where we can actually take viable organs and then the immunosuppressive to minimize the risk of rejection of the transplant. So, and then until 1954, 1963, lung and liver transplant follows by then, and then pancreas transplant in 1966 and 1967, heart transplant. How about in our country? The donation and transplant history in Malaysia. The first living-related kidney transplant started in 1975. And then after that, 1976, we had our first cadaveric or deceased kidney transplant. But there is no coordinator during that time. There is no transplant coordinator. The process, the brain dead patient was recognized by the neurosurgeon, and they straightly referred to the nephrology for the transplant and donation and transplant. So in 1995, we started liver transplant service in SJMC, private hospital. But I think during this time, they only focus on the living liver transplant. And 1997, National Transplant Resource Center was established, and the first heart transplant was performed in IJN. And TRC during this time was only for awareness, not a clinical management, but more to organ donation awareness among the healthcare staff. I remember it was first found by Mr. Datuk Harjit, which is the liver surgeon, as well as one MA to start the awareness program among the doctors and paramedics. And in 1999, we started establish 16 hospital. We call it as top team, tissue organ procurement team, established. But it's very small team only lah. There's one, not a full-time doctor, but only a part-time practice. In 2000, actually, in Malaysia, we had our world first arm and hand transplant, which occur or happened in Hospital Selayang. This was the only time that we performed this hand or limb transplant. And it was not planned. It was very, later on, I will tell about the story about this transplant. And in 2002, we changed the liver transplant service to Selayang Hospital, KKM services. This is not only for living liver transplant, but also for the cadaveric transplant. And 2005, first single lung transplant in IJN. 2006, first double lung transplant. And then in 2007, first heart and lung transplant. 2011, they had their first ABO, incompatible kidney transplant in Prince Court Hospital. 2012, they managed to do it in Hospital Kuala Lumpur. And in 2014 is first control DCD. This DCD is a donation after cardiac death. In our country, we practice DBD, donation after brain death, but we have one or two cases, documented cases, that we actually managed to perform DCD. Later on, I will explain about this. Transplantation in Malaysia. We started with the tissue, of course, the cornea transplant. In Malaysia, we start late 1960s, and during that time, we don't really have a proper program, organ donation and tissue program. So therefore, the surgeon took the cornea from Sri Lanka. And Sri Lanka has started in 1960s. So up to today, more than 2,500 cornea transplant has been performed. And as we all know, the transplant center for cornea is Hospital Sungai Buloh, or the eye bank tissue, the eye bank is in the Hospital Sungai Buloh. And however, cornea transplant is a procedure that can be done in any hospital that has the availability of the cornea surgeon. Even UMMC also perform cornea transplant. And then now where we got the cornea is from the donation that occur in our country, the cadaveric donor, as well as some of it, but it's not enough. The donation is not enough. Therefore, the surgeon are still looking the cornea imported from other country. For example, in United States, and there is a cost to be bear during the logistic cost, which is about US dollar 550. And throughout the practice, some of these logistic costs actually subsidized by the NGO or some CSR. But I think now they are no longer subsidize the logistic costs. So they have to, the patient who receive the cornea has to pay for the cost. Now we go to the solid organ transplant. We started with the kidney transplant, living-related kidney transplant, 50 December 1975. Mr. Martin here is the first recipient, the first recipient, and this is the donor. The donor is the brother of to the Mr. Martin. So it happened in 24, the news is in 24 December 1975. 5-hour operation was performed during the first case. And then followed by cadaveric transplant in 1st June 1976. So Mr. Martin living well with the kidney apparently, but he died of cat poisoning according to the wife here, that the cat poisoning actually causes the problem to Mr. Martin, but not kidney failure, meaning that the kidney that he received is doing well, but unfortunately he had the cat bites, cat scratch, and then he didn't seek immediate treatment, and the immunosuppressive drugs which he took every day, but eventually become sepsis. So kidney transplant at our country, we done or we perform to any ages of group. As of now, we have about total renal transplant 2,299, whereas we had more living kidney transplant than the cadaveric, about 1,679 for living, whereas the cadaveric only 620. Where is our transplant center? In the government setting, we have our transplant center in Hospital Kuala Lumpur, Hospital Selayang, and for the Kementerian MOHE in the UMMC and UITM. Some of other private hospital also perform transplant, but only living transplant. For the cadaveric transplant, we perform in HKL, Selayang, and UMMC. UITM are not doing the cadaveric. What is the demand for the kidney transplant? This is from the MDTR, Dialysis and Transplant Registry. As we all know, the dialysis numbers are very much high, whereas the kidney transplant are very low. And this is good enough to tell public or everyone that there is a huge demand for kidney. And if you see the waiting list for kidney, we used to have about, if you look at the waiting list, the numbers is actually 15,000 to 20,000. And the range is about, now is about 20,000. But now they changed the waiting list criteria. So if you somehow come across the waiting list is about 4,000, but that's not the real picture. The real picture is more than 20,000 actually needed a kidney. Okay, the cost of dialysis. So we are talking about the other RRT for kidney failure, which is a dialysis, which is a good alternative for this good choice of treatment for the patient. However, it is very, very costly, and government also have give a lot of incentives or subsidies to cater for dialysis program. And it's not just about cost, it's about also poorer quality of life for the dialysis patient. Okay, and kidney transplant, according to NTR, National Transplant Registry report, it has a good success rate. Even cadaveric is comparable to living related. For 1 year survival, actually, this 2005, to 85%, and living related 96%. The latest, as I heard, cadaveric has improved up to 89%, actually, the first year survival. And in some studies shows actually living related has a better immediate graft function than cadaveric, but for long term, living and cadaveric has about similar graft function and survival. Okay, and kidney transplant markedly improve quality of life, and then able to work, marry, have children, and be involved in active sport. Just recently, I have a forum with the nephrologists, and they also and knowledge about this quality of life from kidney transplant patient. Therefore, we are pushing for transplant than dialysis. So one cadaveric kidney donor benefit for patients with kidney failure. This is this is the mathematics of donation, disease donation. So one cadaveric donor, we transplant to 2 recipients. Then therefore, they no longer needed their dialysis slot. It will be given to another 2 patients, ESRF patient who needed the dialysis. So indirectly, it saved about 2 and another 2 patients, 4 patients. Now we go for liver transplant. Liver transplant started in SJMC since 1995, living transplant only. And we moved to Selayang in 2002. And at this moment, this has to be corrected. Not only done in Selayang, it has also done in UMMC. UMMC started with the living transplant first. We are going towards, we have some discussion also to start offer cadaveric liver to UMMC as well. So 175 transplant done to date locally, and about 89 numbers of it are from cadaveric donor. As you can see, the numbers of transplant from kidney and the liver, we have more living than cadaveric. This is not the way it is supposed to be. By recommendation from international practice, that we should actually focus more to cadaveric than a living transplant, because living is always a complementary for the cadaveric. Okay, requirement for liver transplant is hard to say. For PITS cases, it's about 20 to 25 PITS cases per year. This is from NTR report. And adults numbers are undetermined. But in our waiting list, we have about, we can say about 5 to 10 patients in our waiting list every month. But I believe the numbers can be high. It depends on the center, the transplant center. And for the 1 year patient survival, more than 10 years age group, 88%, 0 to 9 years age group, 66%. Then we go to IJN, Institut Jantung Negara, for cardiothoracic transplant. And first heart transplant in 1997. This is the picture of the first heart transplant here. And he is living with the heart about 3 years only. He died of lung cancer. And number of transplant to date on only 28. And there is no pediatric transplant. And the survival rates in the global rates, 83% 1 year survival, 63% for 5 years survival. This is not so many of heart transplant, because their selection criteria is very, very tight. It's not easy unless they can actually do some expansion or expanding the criteria. And speaking of even the survival rate or global survival rate is about 63%, 5 years. But some of the example we can show to you that patient has been living long enough for the heart transplant. This is in the world record. Tony Huseman has died 31 years after being given a new heart. And other long-term heart survivor actually are very healthy and very competitive when after they receive the heart. Even a normal patient without heart transplant also unable to do what they can perform. This is some of the story here. Kelly Perkins, climbing mountain, Ironman competitions, and so on, so forth. And what about in our country, Malaysia? Do we have a longer survival heart transplant? Yes, we do have. This is Uncle Gunaratnam here. And heart transplant done in 1998. So now it's 2022 and he's still living healthily with the new heart. All right. So this is very long. Okay. Well, how about our waiting time for donor organ in IJN? Unfortunately, in IJN, the donor waiting time is not good. Shortest time 1 week, and in your fortunate situation, you get in 1 week we have a shortest time. Longest time more than 26 months, average 150 days. And 40 heart patients died while waiting. This is the story of, we call it Fikri here, the first patient in IJN who received VAD, a ventricle assisted device. So VAD is a treatment in the IJN that they perform for the patient, what we call is a bridging treatment for heart failure patient. For in the time that they have to wait for heart transplant, they will put on this VAD. So during this time, VAD device can sustain or can maintain the heart failure patient for duration about 2 years only. In within 2 years, the patient has to receive a new heart. If not, they will die. But I think as the medical advance, as the device advance, this is the battery last time. But now the battery is not like this one. It's smaller. So Adik Fikri is the first patient who received this VAD, and he successfully or fortunately received a new heart as well within the time before during the waiting for the heart in the 2 years duration. So after he received the new heart, like I mentioned in my previous slides, that the transplant patient are very much can live as normal as it is. And for heart patient, you know heart failure, how bad is heart failure for a patient. They don't even can, macam Adik Fikri ni, dia nak makan pun kena bersuap. And so very weak. And then after new heart, this is what he can perform. And Hu Yi is another patient who received the heart transplant, and we call it miracle girl. Why we miracle girl here? Because as you can see, 2 suitable donor in 24 hours, a huge stroke of luck. Later, I will explain why this is so lucky and so miracle. First of all, we have to understand the donation is not, the organ donation is not huge in our country. And Hu Yi, when she first received the heart transplant, she faced acute rejection, immediate rejection, graft rejection. So after the transplant in the ICU, memang masa tu the BP drop, very bad rejection. Dia punya badan tak boleh terima langsung kan. And masa tu doa sahaja yang diperlukan lah. The physician, the surgeon try to maintain as it is. And the surgeon said she need a new heart. If within 24 hours tak dapat jantung baru, she will die. And fortunately, somehow rezeki dia lah dapat ada satu donor lagi, cadaveric donor from I cannot remember. And luckily also the donor is matched with her. The size is matched, the blood group is matched, and everything is matched. Then they can perform the transplant for her. All right. But some of other heartbreaking weight in IJN. There is some other patient who success and who is not success for transplant. Tan Get Kun here is one of the story that very much success received the new heart, whereas the Winnie Chen here is not. Okay, this is the story of Winnie Chen and her heart of gold. Winnie Chen is one of the patient in the waiting list for heart, and she's been waiting about 800, more than around 800 days in the waiting list. And unfortunately, she died in 2010, Tuesday, 11 October 2010. She was only 25 years old. After she died, she actually became a donor. She donated all of her organs on the death time of death. She donated kidney and eyes. This story is not right. She didn't donate lungs. She donate eyes, liver, and kidney. So this is the interesting story because for someone who actually waiting for organ, but they actually become a donor. And because to say when the doctors ask the mother, why she want to do this, because she said she understood very, very well the suffering of people who's waiting for organ. Actually, she doesn't want anyone waited for so long like what she has faced. So yeah, she become a donor. For lung transplant program, the surgery conducted in the IJN, the cardiothoracic surgeon will be in the IJN, but the physician who managed the lung transplant is in the, previously it was in IPR, but nowadays it has moved to Hospital Sedang. And as other organs to be compared with lung transplant lagi ramai yang meninggal ketika menunggu because they are really in the bad shape when they were in the waiting list on the, depends on the oxygen, risk of the lung infection and all. So yeah, and the selection criteria for donor for lung also very, very strict. We offer sell a lot to them, but not all can be fit into the, can be taken for transplant. Just now I mentioned about arm transplant baby goes home. This one yang in 2000 in Hospital Selayang, Choh Li Ying, the first infant to go an arm transplant in the world. This is the first record by the vascular or microsurgery department in Selayang Hospital, Dr. V. Padmanathan. So because she was born with a twin, so there is no issue of rejection of the limbs or so the other twin actually died because of severe malformation, and whereas she was born with deform of the limbs. So the doctor decided why not they took the limb, the normal limb from the deceased twin and transplanted to her. Okay, from the story just now, what we can conclude, that's all this transplant in Indonesia. The success, the program, the service, the survival rate, the demand of the patient. But all of them will not happen if there is no donor. I really emphasize, if no donor, no organ, no transplant. We can train many surgeons to do transplant, but there is no donor, no transplant. Okay. We have two types of donor, living donor, as you all know lah. One kidney and part of liver, bone marrow, and also a deceased donor, cadaveric donor, selepas meninggal dunia. We have what we call brain dead donor, or in DBD lah, donation of the brain dead, and DCD, cardiac death circulatory donor. So in Malaysia practice, we only do DBD for all organ and tissue, and cardiac death for tissue only. But in international definition, actually, both type of death we can take organ and tissue. That's why they call a DCD organ donor, donation of the cardiac death for organ. But that's another story. Okay, process involved in donation, cadaveric donation. First, we have donor detection, identification, and then we have to brain death certification. Okay, in cadaveric or deceased donor, the number one rule that we must obey is what we call as dead donor rule. Every deceased donor must be certified dead, must be confirmed dead. Either it's DBD or DCD, we must confirm death first. We cannot take from patient is still alive, okay? And donor maintenance and the organ don and then followed by donor maintenance. So we call it donor maintenance or donor, some place they call donor treatment, or donor management or something. So in DBD or DCD, as the death occur, but the organ must be maintained if you want to use for transplant lah. So that's another process. And then after we maintain, we go for request of organ donation, family approach or organ donation, counseling or request. And then we go with the assessment of organ function and suitability as donor. And also the last but not least, actually, logistic or arrangement of the coordination, procurement, retrieval, and recipient team as well. Okay, This is overall the process will involve in the cadaveric or deceased donor. Usually in emergency department, will involve in the first process, donor detection and identification. I know it would conflict a bit about uh, your job, but you can become the champion or focus person in emergency to identify what we can say as a possible or potential donor. Okay, the next process involve as well as the medical legal clearance from any cases which has medical legal documents or report police and so on. So they have to get the clearance for the police in some places, overseas coroner and forensic, of course, a forensic pathologist lah. And some also needed post-mortem. And we follow by the family support. Okay, for our job, donor side, we like my job or any other team involved in donation side, we are advocate to the donors and their family members. So we have to give support to family members. Okay, and then we arrange for the multi-organ procurement surgery. It's either single organ or single tissue or multi-organ surgery, retrieval surgery. And then we arrange the other after that it didn't stop until we took up we took out the organ, then okay, that's it. No, we still we have to give support until transfer the body at home, and last rites ni maksudnya kita arrange for them lah, but and then later of appreciation, this is a long term process lah, where after the donation we give some appreciation to donor family and debriefing among the medical staff yang involved with the process, and then finally we put some registry lah. Okay, so this is the what I mentioned about the crucial part of the process for cadaver donor identification. So where we want to identify the donor, of course DBD, as we mentioned it, is majority happen in the ICU, it is an intensive care setting. So we need proactive rounds. Okay, kita sometimes we have to rely on like macam passive detection. When the family initiate baru kita start. But we do need proactive round. Therefore, we have a dedicated team in every hospital. I believe UMMC also have what we call as top team. So to do daily rounds every day, because kematian berlaku setiap hari. The occurrence of brain death, cardiac death. So this is in the critical areas, ICU, HDU, neuro ICU. In our hospital, we have neuro ICU and also emergency and forensic department for cardiac death. For the CD lah. Okay, then we refer the case. When we identify the case, then subsequently we refer. For the brain death, the heart beating donor, heart brain death also we call it heart beating donor for organ and tissue, and to see the viable, because it's a viable organ function. And generally, there is no absolute contraindication for brain death. We can still refer and discuss about the suitability, medical suitability of the donor. And then we have a non-heart beating donor, cardiac death, for tissue only. Okay, this is what practice in our country. But there is such thing as a DCD donor for organ. There is another classification, what we call as metric classification for DCD donor. There is a 5 category, and usually for emergency department, the first category and the first and second category apply to emergency department setting lah, when patient came in asystole or when patient asystole after resuscitation. So that's another story. In the world, Spain is the country who practice category 1 and 2 DCD donor. So they will, patient asystole, they will restart balik jantung lah. And what is the unsuitable donor? In general criteria, HIV and other transmissible infection like hepatitis C might not become a suitable donor. Hepatitis B apparently initially was not suitable, but now our recipient team has considered to take hepatitis B in their expanded selection transplant. To hepatitis B patient also, which has antibody or surface antibody titer high, so that they can transplant safely lah, and then we start the treatment. Okay, malignancy, malignancy except for primary brain tumor are not suitable. Some brain tumor also there is a list of certain brain tumor that can be accepted and not accepted for the donors. Again, we have to discuss with the donor coordinator or your team, top team, which we think is suitable for donation or not. Multi-organ failure or sepsis are not suitable donor, and systemic disease or infection like tuberculosis also are not a suitable donor. Okay, this is a critical pathways for organ donation. This is from Spain, Transplant Procurement Management Spain, Donation and Transplant Institute. So we are trying implementing this to our setting as well. What is the critical pathway for organ donation? Because we have a missed donor actually. Kita banyak missing opportunity to have a deceased donor. Therefore, we come up with this pathway. Possible organ, we identify as early as possible deceased donor. What does it mean by possible? A patient with devastating brain injury or lesion, or a patient with circulatory failure, this one for DCD lah, and apparently medically suitable for organ donation. Okay, apparent medical suitable for donation. This is a possible. Then we go to potential DBD brain dead donor, a person whose clinical condition is suspected to fulfill brain death criteria. So kita suspect patient brain dead. How we want to suspect? Later on, I will show you the slides. Eligible brain dead donor, a medically suitable patient who has been declared dead based on neurological criteria as stipulated by the law of the relevant jurisdiction. This is after kita buat brain dead test, okay? And later on, we will become actual DBD donor, a consented eligible donor with whom an operative incision was made with intent of organ recovery or organ retrieval for the purpose of transplant, or from whom at least one organ was recovered. And subsequently, the final pathway is utilized lah. One of the organ yang kita ambil, kita dapat transplant. That's all. So what is the reason potential donor does not become utilized donor? This is some of the reasons. We go by the system. Kita fail to identify or refer a potential or eligible donor. And brain dead diagnosis was not confirmed. Why? Some of it maybe because of does not fulfill the criteria or completed. A lack of technical resources or tak ada pakar yang nak buat. Kadang-kadang kita ada masalah lah. Kan? Sebab kadang-kadang kita nak buat brain dead test ni pukul dia tak menentu. Maybe pakar busy ataupun not available. And then circulatory death, not only circulatory death lah. Okay, this one for DCD. And then logistical problem. Sometimes we face that kita dah dapat donor semua tapi kita tak boleh move or mobilize our recovery retrieval team. This is an issue actually. Sometimes kita bergaduh dengan our retrieval surgeon nak suruh turun ambil organ. Alright, and then lack of appropriate recipient. This is also another issue actually. Sometimes we have a donor, kita dah dapat organ, tapi bila kita tanya our recipient team, oh tak adalah blood group A positive ni tak ada pula dalam list or whatever it is lah for many reasons. Some other reason are donor or organ, medical unsuitability, probably suddenly turned out patient got some HIV later on kan, and then hemodynamic instability, unanticipated cardiac arrest. Kita dah maintain the patient, suddenly cardiac arrest and then we cannot do the DCD. So it's a failure lah for us. Okay. Anatomical, histological or functional abnormalities of organ. Suddenly when we open, the procurement team open the body, suddenly got a mass or the kidney cyst dia dalam ultrasound nampak macam simple cyst, but it actually looks not a simple cyst lah, macam malignant. Okay. organ damage during recovery, kadang-kadang this is a very commonly occur juga. The organ is not damaged, the structure damage lah. Sometimes short, dia terpotong short ureter or short artery, so it's difficult for transplant later on. Inadequate perfusion of organ or thrombosis. So one of the things that they do during recovery of organ, they have to perfuse the organ to make sure the vessels semua clear of thrombosis lah. So sometimes tak cukup perfusion menyebabkan dia berlakunya thrombosis dan cannot be used the organ. And finally, the permission issue, we cannot give the consent lah. And also we have issue when there is a refusal from magistrate or police. There is one or two cases that we are being refused by the medical legal department. Okay, this is tadi saya mention kalau kita ada potential donor, kita ada suspected brain death. How do we suspect brain death? That's where we come with the clinical trigger for organ donation. This is in Australia. They have a GIVE, GCS less than 5, I intubated, V ventilated patient, E end of life care lah. That means that the DIR patient or DNR patient, and there is no other management to follow. Okay, this is in Australia. There we come up in our country, almost similar, GIFT, we change T only. GCS 3 and 315, I intubated and ventilated, F fixed and dilated pupils, T treatment is futa. So give your patient a chance in sharing their gift to others. So normally we know that we after the patient, when the patient is in the poor prognosis or we treat conservative to the patient and we flag with the DIL on no resuscitation anymore. But for donation, for management of end of life, we should consider to care of the patient for donation as well. And we don't end the hope at that moment only lah. Okay. So brain death account about 2 to 4% of all hospital death, and it is higher in neurosurgical or ICU setting lah, 13 to 15% in the neurosurgical ICU. Okay, definition of brain death is a death of the whole brain, including brainstem. Absence of brainstem function in deep coma, DCS3. On ventilator, patient cannot breathe, apneic, non-cause of irreversible brain injury pathology. There must be a causes for the condition, and it has to be some investigation that can prove the causes, like particularly in this case is a CT scan or MRI, semua lah. Other reversible causes of coma has been excluded for this condition. So the underlying causes of brain death, we have intracranial injury, or which is bleeding or cerebral edema, and traumatic. It can be divided with traumatic brain injury, as well as the spontaneous bleeding in hypertensive or rupture of aneurysm, AVM. And also there is a cerebral infarct or thrombosis that can also cause brain death, tumors, hypoxias, and others. Okay, brain death certification. In our practice, in our consensus, two specialists trained in brain death testing, usually anesthetists, neurologists, and neurosurgeon. And they are not involved in transplant. So basically nephrologists, hepatologists, they are not recommended to do the test lah. There will be a conflict of interest. And usually kalau specialist tu dia merawat patient tu, also kita tak recommend also. I mean the primary team, kalau neurosurgeon contohnya dia yang that's his patient, we are not recommend him, but we can recommend other neurosurgeon to do the test lah. Okay, 2 tests performed by each of the specialists, and period of observation between tests, and in our consensus is 6 hours between the first and the second test. And then brain death confirmed when second set of tests completed by both specialists. Must make sure kena buat dua specialist. Sometimes Dia buat satu orang je buat, satu orang tengok je, but we want to avoid this, please to do as recommended in the consensus lah. Okay, the clinical testing of brainstem, we examine or we assess the cranial nerve, both pupil unreactive, corneal reflex absence, ocular cephalic, the doll eye test absent, ocular vestibular, cold caloric test absent, cranial nerve motor response is absent, and gag and cough reflex absent. And for the apnea test, the hallmark of the brainstem assessment is the apnea test must be absent lah. When the arterial blood gases to CO2 more or equal to 60 millimeter HD lah, and pH less than 7.3. Okay, brain death is death. Okay, death certificate will be issued, ventilator will be turned off, regardless of organ donation or not. This is the procedure or medical test that we will perform in every suspected cases. But this is the opportunity for organ donation, as I explained in the previous slides. This DVD donor, this is what we call DVD donor. The organ is still in a good condition. So the diagnosis of brain death is a clinical diagnosis. In our consensus statement, is a clinical diagnosis. So kita kena buat clinical diagnosis tu, and then confirmatory test is not necessary. The what we call it as the ancillary test or confirmatory test or imaging test, it's not necessary. It's only indicated in certain situation. Probably in a situation where we cannot perform apnea test for some reason, the injury or the condition, the apnea test we cannot perform. So we do every other components of test, and kita tambah ancillary test lah, maybe one CT angio or EEG to supplement the clinical test just now. So in our setting, we must do the clinical diagnosis first. And the consensus is in 2003. We're supposed to update this consensus because the first consensus is in 1995, and then this is the second consensus, 2003. So we have asked the relevant team to look into it. Okay, this is donation. As I may explain in the previous slides, and I emphasize here, this is the preferred type of donation. There is no more risk to the donor. Okay, because patient has died, there is no other risk. Many organ and tissue can be donated from one deceased donor and benefiting a lot of recipients. Many recipients. Without deceased donor, macam mana orang yang perlukan heart, lung, eyes to have a transplant lah. Okay. It can benefit a lot. Okay, this is one of the example to show you this a real story of donation. Teo Chit Hua died of brain tumor in 2006, and he donated everything that can be used in the body, from top to bottom, skin, bones, lung, heart, liver, and kidney, and benefit about 35 people from the donation. And as I mentioned, this is donor ni they have a larger pool of donor because we all understand that in our country, Malaysia ni dia banyak motorcycle semua kan. So we are top 10 in the world to have road mortality accident. About 6,000 to 7,000 per year. Even I checked in latest statistic also, it's about the similar numbers of road traffic mortality. So average 18 people needlessly die in road traffic accident a day, mainly young and healthy patients. And even if only 10% of these accident victim cases and the family agree to donation, what will happen? No, patients perlukan a longer waiting list to save their life, like Winnie Chen just now. Tak perlu tunggu sampai dia meninggal pun dia boleh dapat transplant. And number two, no other living patient should be subjected for living transplant. Because of cadavery is so low, some people are desperate. They will go for living alternative transplant. And the ethical concern about living transplant is we shouldn't do harm to any healthy patient, and not necessarily, although we know it's a desperate measure, but it's not necessary pun sebenarnya, kan? Okay, the process of when we saw all this happen for deceased donor and the grieving family, this is a very delicate process in the whole category donation, which is family communication and donation conversation. And this is not an event, this is a process. It will start at the moment that you identify the donor in your hospital until you get the consent. So the process, this is from Gift of Life Institute, United States. They outline five process here. First, we have to information gathering and sharing, team planning. Bila you nak jumpa family also, you need to plan. And then family given grief prognosis. Team explain about treatment and then support, question and answer. Okay, given dia punya withdrawal of treatment semua tu, decision is finalized and decoupling with the brain death and ni lah the treatment ni and grief support and donation conversation akan dimulakan lah, and finally closure, final needs and aftercare of the donor, and never neglect the family who has given the consent. Okay, how we allocate the organ that has been retrieved? First, by best match of the donor and recipient, blood group, tissue matching, the HLA typing, and the size. In the case of lung and heart, they have to look at the size of the donor and recipient. And number two is based on the urgency. Urgency of the patient in the waiting list, who needs more of the organs. And number three, based on the position on the waiting list, who has been waiting for so long or in the high waiting list should be prioritized. And nowadays, we have what we call as a Malaysia Kidney Allocation System. This created by the Malaysia Society of Nephro together with all the nephrologists. This is only for kidney allocation system. The rest of the organ, they have a waiting list on their center, like Selayang. Selayang has their own waiting list. I think UMMC also their own waiting list for liver, as well as for IJN, they have their own set of waiting list. For kidney, they use a nationwide waiting list lah. All right. This is the donor rate per million population, actual organ donor and tissue donor in Malaysia, as we can see from the graph from 2010 until 2020. The graph mula-mula naik, and then 2015 we have the highest numbers, and we started to decline, and then we started to pick up. Even in 2020, when pandemic happened, we still have about 41 organ and tissue donor. And WHO acknowledged this achievement to say that Malaysia is one of the country that has increment, top 10 increment during pandemic for the organ and tissue donor. Don't ask me about 2021 because it's so low. We only have about 7 organ donor. That's the last year is very bad for the activity. And up to today, actual cadaveric donor is about 762. Number of transplant has been performed, 2,605. Number of donor register or donor pledger, about 500,000 lah. 500,000 orang telah berikrar. In waiting list, as I mentioned, if you look at the waiting list, it's small, 4,737. But it's not like this actually. The real picture, there is always a patient who needed the organ. Even for kidney alone, it's supposed to be about 15,000, but they clean up the waiting list actually. Now the waiting lists are more to patient who can benefit the best for the organ, because they don't want to give the organ for a patient who may not survive longer. So they give to the best outcome patient. Now let's see our donation and transplant activity to be compared with other countries. Just look at the first table, first line of the table, category donor per million population. This is in 2013. But in many years afterwards, also the numbers are lebih kurang sama because Malaysia is still at the bottom of the list. So we look at the Spain. Spain is the highest numbers of donation activity for category per million population. Is very high. Is a role model for other country actually, and United States is also high, and all these the highest numbers we can look at the Western countries, European countries, okay, and then we look at the Asian country. So Malaysia, to be compared with our neighbor, Singapore also higher than us, about 4.6 donor per million population. Hong Kong is about 6 donor per million population. And then we compare to the Islamic country, Saudi Arabia and Iran. Iran also has very high. Iran actually in the overall Islamic country, Iran is the highest, 11.43 donation population. And then Saudi Arabia, to be compared in Malaysia, also they have Islamic conservative practice in the country, also higher than us. What is wrong with our numbers? It's very low. Okay, and what is the secret of Iran to have higher numbers in the among the Islamic country? They champion their donor coordinator. Iran is the country that they champion their coordinator. The donor coordinator in hospital in Iran, they have more power. If they said this is the donor, you have to give the donor. They can overrule their primary doctor punya decision, because sometimes we have a argument to select our donor. So in Iran, they empower their donor coordinator to have a proper detection and management. Okay. And in Malaysia, why we have a lack of donors? Some of the reasons that families mention and refuse to give consent, causing pain and cannot accept brain death, against the religion, mutilation and all. But most of it because they does not know the wishes of the deceased. They didn't know the wishes of the deceased. They are not sure whether the deceased wanted to donate or not. So they cannot decide. And family consent 51% in 2011 versus 25% in 2000. We have improved also in our family consent over the years. But we cannot blame family. We cannot say everything is wrong with the family tak nak donate lah, sebab ni, sebab ni, sebab ni. But some of the reason actually because the medical professional actually didn't fulfill their wishes. This is some of the story lah, from Kajang, this one. Corneas wasted all due to nonchalance of staff. Because the medical practitioner, the medical healthcare didn't know what to do. When patient came to you, family came to you, okay, kita nak donate, tapi kita tak tahu nak buat apa. Then we have just let go the opportunity. A noble organ offer that went to waste, heartfelt wish denied. So some of the story that complained by the donor family because they want to donate, but the hospital, the team didn't know what to do to the donation. Delay upset donor family. That's why I mentioned we are the advocate for donor family. This is the wish. This is the wish. This is a gift. So when people want to give something or to wish something, we have to fulfill this. We have to make sure the donation happen as best as is to fit the family request. Okay, what happens when we have a shortage of category donor? This is donor. Then we have to depend on the living related transplant. And that's where the commercialization organ transplant happen. People go overseas, China or India for transplant. And then we have to use marginal donor. Marginal donor defined as donor yang bukan dalam general criteria just now. Maybe we have to use HIV donor. Maybe we have to use hepatitis C donor. Where there is no other fit donor, right? Maybe kita dah tak boleh nak memilih sangat lah, kan? If donation rate berapa tadi 0.2 donor per million population, then we cannot be so selective. This is what happen if there is very much shortage of the donor, category donor. Living donation. Speaking of living transplant, there's always risk to the donor. Everything in the surgery not without a risk. There must be a possible coercion sometimes. Donor and recipient ada unsur-unsur paksaan, exploitation of the poor, vulnerable of the poor, commercialization of human organ and tissue organ trafficking. And in Malaysia, we accept only for living-related donor. Unrelated transplant, it can be allowed, but with a controversy lah. Speaking of the living donor, like I said, there is a mortality risk, 0.03% of mortality risk for kidney. It's a very small mortality risk, but it's still a risk, and it has happened. And major morbidity risk and minor morbidity risk. Okay. Like I mentioned just now, long-term evidence, 50 years, has demonstrated the relative safety of living, showing no impact on longevity or quality of life. Because in long term also the kidney subsequently will facing some orang kata function dia dah berkurangan lah, reducing in function and so on. Alright, risk to the this is a liver donor. Liver donor living dia ada higher risk than the kidney. 0.5 to 1%, morbidity 40 to 60%. Okay. In international practice, in some European countries, they started to move away from living liver donor. They in some center, transplant center, they didn't want to do living liver donor at all. They will only focus on the cadaveric donor because there is the risk of liver surgery is very, very high. And even in Malaysia, actually, we stopped for a while. In 2014, actually, Hospital Selayar stopped doing liver living donor because there is a risk for the patient. So they stopped and they only focus for cadaveric. Now we started our living transplant. So yeah, but we at our best we want to improve our cadaveric donation for liver donation. And what we call about the living related is actually first and second degree family, parents, children, siblings, grandparents. Now including wider degree of family relationship. But we have to ensure there is no commercialization involved. Unrelated living transplant, like I said, big controversy, slippery slope to organ sales. There is no way we can monitor or regulate or penalizing, especially in Malaysia, because we don't have a proper transplant law. We don't have a relevant law yang betul-betul transplant law untuk implicated to this activity. We only have about medical ethics law, medical act, and also human trafficking act. This and two other law that we can implicate for this practice lah. And the position of MOH, we are not using living unrelated donor, not generally used, only exceptional circumstances. There is no compatible or suitable living donor, and there is no alternative life-sustaining therapy. In some situation for the liver patient kan, acute liver failure semua tu, they are very much in need of very emergency transplant lah. Okay, donors' motive must be altruistic, must be fully informed all the potential risks and outcome. And we have to obtain with the special approval from unrelated transplant committee. Okay. And we upheld the WHO resolution regarding the human sales and organ purchase of human organ. And kita ban on all types of advertising, soliciting or brokering, and penalties that for acts that aids, encourage or use product of human organ trafficking or transplant commercialization. This is China. What happened? This is what happened in China when they actually took organ from death penalty prisoners. So it received a bad press from all over the country, all the world. This is some of the cases that they believe that this doctor involved in the kidney transplant, illegal kidney transplant. And then some of the story reported cases 6 children in South Africa mutilated and reportedly organs sold. We read this news sometimes, and even happen in our country, but some news are true, some are not true. Donated organ is foreign to recipient unless it comes from identical twin, and that's where the immunosuppressive are needed lifelong. So in one of the way that we want to prohibit overseas transplant, illegal overseas transplant, we have to provide immunosuppressive. Free only it is been done in the country. And this is our act legislation implicate for the cadaveric donor organ donation. Then we practice opting in law, express consent required from the donor or donor family lah. Okay. This is our policy book, National Organ Tissue and Cell Transplant Policy in the June 2007. This is our registry book lah. Nowadays we can refer the registry online. And then from Islamic perspective, accepted by all religions in Malaysia as it is the most generous and charitable act. And this is Muzakarah Fatwa Kebangsaan in 1970. It's mentioned about the transplantation from the dead person to a living patient is permitted. This is in 1970, and up to today, there is a new fatwa all over the states, because we have so many states, and every state also membenarkan lah penemuan organ cadaveric, which include every other organ as well, kidney, liver, semua lah. Okay, this is just to mention about donation Muslim cadaveric donor. Actually, it's not 64 now, it's 89 cadaveric donor nowadays. So the issue donation rate in Malaysia, what we can see is there is not so many Malay donor. This is the problem happening in our country. The majority of the people in Malaysia are not donating, which is the Malay ethnicity. This is not happen in other country like Australia or United States ke mana-mana, whereas the majority people, the Caucasian donate more than the minority person. So this is the one of the dilemma happening in our country. But having said that, what we can see the trend of donor register, the Malay donor register has increased tremendously for the last 10 years. So we can see now the trend, the awareness and the donation awareness has actually more aware in the donor in the Malay ethnicity, that they have tremendously increased in the numbers of pledges. And I think as of now, Malay about almost 200,000 of pledges actually, 200,000 almost. This is our pledger card, donor card. We believe that if we register, then we can become a donor. Not necessarily, less than 20% in our actual donor is actually a donor register or pledger. The rest is not a pledger or not a register. The family has the right to decide for you lah. Okay. Seperti some of the stories lah, tidak perlu berdaftar juga untuk menderma. Sometimes you don't need to register, but you just have to inform your loved one. Kalau apa-apa saya nak donate ataupun saya nak bagi organ saya pada sesiapa sajalah. Okay. Okay, this is some of other story also. And what about the age? There is no selection criteria age for donor ni. Dia tak ada very specific. As old as you can go, 70 years old, 80 years old, you can still can consider cornea donation. And for kidney donation, you don't consider your chronological age, you consider your biological age. You look at the function of the kidney during the time of death, it is still good. Baseline creatinine macam mana, kan? We can still consider. Our oldest kidney donor is 70 years old for cadaveric. And it is one of the best kidney that has been transplanted according to the surgeon. The moment they transplant je, patient boleh kencing. Even best as living punya transplant. This is the oldest kidney donor. And for the youngest, usually 2 years old for the solid organ kidney, 2 years old and above. Below than that, we can still consider cornea donation. Cornea and kidney ni are the most, orang kata, very flexible in their punya selection criteria, not compared to the rest of the other organ tissue lah. This is one of the example, a 2 years old Esther Lim Joy, who died 2 years and 9 months. So because of brain tumor, and then she became a donor lah. Okay. Okay, what is the best or what benefit of you become a donor register and you become donor cadaveric donor? It has a positive effect to the recipient, save many life, allow the blind to see lah for cadaveric cornea donation, markedly improve quality life for certain recipient, for tissue recipient. Positive effect to the recipient family, positive effect to the society, most importantly, positive effect to the donor's family. And for your information, and as my experience in NTRC, there is no single donor family has complained their decision when they have decided to become to give permission. Tak pernah ada seorang pun yang complain semula lah. No one has complained again to us, kata menyesal ke, saya menyesal memberikan keizinan. No, there is no family yang pernah rasa regret lah. Okay, semua rasa benda tu yang terbaik yang mereka telah berikan. Okay, I just want to emphasize our National Organ Donation Week in 13 August this year. This is one of the program in our Organ Donation Week, whereby we appreciate all of them is actually our donor family. This is all of our donor family members. This is our Timbalan Perkembangan Perubatan last time, Dato' Bahari, our national head dulu, Dr. Omar. Okay, this is all donor family who's involved. You look at them and you see that we didn't give them banyak benefit. Kita kasih dia duit 1 juta ke banglo ke luxury car, but we only give them this token of appreciation, certificates, some of flowers lah kita bagi. But they looks happy. This is the charity that they can still give even when their loved one has passed, tengah meninggal dunia atau is dying that time. So yeah. So this is our toll-free hotline, our on-call numbers, the transplant coordinator. If any cases, you can jot down if you can call for any referral. And this is our email, our website. This is some of our education materials. If you want to have this also, you can refer to us. We can provide for you. This is my final slide. Without organ donor or tissue donor, there is no story, no hope, and no transplant. But when there is an organ donor, life springs from death, sorrow turns to hope, and a terrible loss becomes a gift. Thank you.
Thank you, Dr. Hasli, for the nice presentation. So now I will open the floor for question. For the online participant, you can place the question in the chat box. Tak ada question lah. Tak ada soalan. Oh, hi Dr. Hasli.
Hi.
There's one question. How about COVID patient? If they can, can be a donor as well? How long they have to wait after post-COVID to be a donor?
Oh, COVID patient. This is very interesting. Nowadays, everyone asks about COVID patient. We just discussed about COVID patient the other day. We have kita ada set a new guideline for COVID during pandemic lah, donation and transplantation during pandemic. As per our guideline, patient who died due to COVID are not permissible to become a donor lah at the time of death, and then the COVID PCR test turned out to be positive and so on. Kita tak boleh jadi donor for that patient. for the COVID patient yang dah recover from COVID, they should be recovered for at least 21 days from early diagnosis to, and after 21 days after that then they can become a donor lah. And then this has yet to revise about the COVID patient, and in our experience also during 2 years before this, we haven't had a donor yang memang even during diagnosis or retrospectively also tak ada yang a true COVID positive donor lah. But in overseas experience, they have started to actually expand that criteria to COVID patient as well, COVID donor as well. So for non-lung donor, some transplantation from COVID patients somehow didn't has some there is no issue lah. They only more strict and more observed towards the lung donation from the COVID patient. So as of Malaysia, what we practice, we have to still not accepting any COVID positive donor, and for who's recovered, 21 days lah. Okay. Any other question?
Thank you, Dr. Asif. There is one more question from my colleague, Dr. Shali. Hi, Dr. Asri. My name is medical officer. Actually, my question, if patient come to red zone is cardiac arrest, so I already adequate resuscitation and then patient no return of spontaneous life. So now inside the pocket, I noted the organ donor card. But how I still need to get the family member concern, because sometimes family member don't know this patient is actually organ donor. So I need to still get the family consent, or I can proceed with the organ, activate the organ transplantation team.
Okay. Interesting question. As much as in emergency setting, kita boleh tahu kan the status of organ, like you said, the donor, the presence of donor card, and but we are still bound to our legal punya practice lah, our law as required in the Human Tissue Act, that we have to get consent from the donor family. But what is the purpose of having the donor card then? So when you approach the donor family, you have to mention or you have to inform, okay, we found this for your loved one. Kita dapati arwah siapalah, we want to name the patient, dia memiliki donor card. Adakah family tahu pasal hasrat dia ni lah kan? And then if the family maybe dia akan cakap tak tahu ke apa ke, what we believe this is what he want lah, because ada donor card. So benda tu sebenarnya akan influence the family decision. In the end of the day, kita memang kena minta family decision, but we can influence them based on the donor card. Okay, I want to share you a story. Our donor in northern region in hospital Alostar or hospital Kanga is a Malay. He is a lecturer who died because of accident, traumatic brain injury, masa dia nak pergi kerja, and he's a Syariah lecturer. So Ustaz lah, we call him Ustaz. And then when he actually has registered as a donor, but parents didn't know, the family didn't know. So what happened is when he died of brain death to the hospital, and then the doctors noticed that he is a pledger, he's a register. So when they approached the family members, initially the parents, both of the father and mother, refused because they have a very strong Islamic background yang memang dia rasa organ donation ni salah. But then when the doctor emphasized there is a donor register, he is a pledger, dia pendaftar, and then bila family dengar, one of the brothers also emphasize the same thing. Dia kata, oh yes, this donor memang this arwah pernah bagi tahu dulu dia nak donate ni. And then the parents, mother and the father, changed their mind. When they saw the pledger status, they changed. They said, dia cakap macam ni, kami sebenarnya tak bersetuju. Tapi kalau ini yang arwah nak, kami tunaikan. We fulfill the wish. So yes, that's what I can tell you lah. So in our Human Tissue Act, we still need the consent of family. And the purpose of the donor register donor card is to influence the decision. So we still have to approach the family members. We still we still have to get the consent from them, and we should have the proper conversation and discussion towards that decision. Okay, thank you. Is it okay?
Okay, Dr. Asri, thank you. If there is no more question, I would like to end our CME for today. Thank you again from the bottom of my heart, Dr. Asri, for taking time from your busy schedule to be the guest speaker at our CME. So with that, thank you everyone. Bye. Assalamualaikum.
Okay, salam.
Okay, bye. Dah.